So what we like to talk about here is bereavement, or basically hydrodissection and scraping of tendons for degenerative tendinopathy. We'll talk a little bit about the rationale behind using this. I'll end with a kind of review some of the evidence, but I'll also give a case example of an illustrative case that we've done in the office. So, Dr. Hosopo has gone over this, and I won't spend too much on this, but this is just to remind us that tendinosis, or degenerative tendinopathy, is a lot of different things, okay? And it's often taught that it's very different from tendinitis in that you have this kind of degenerative infiltrate rather than a classic chemical inflammatory infiltrate. So here again, you got your electron micrograph showing a normal tendon above, not electron micrograph, this is just a histological slide. EM's pictures are coming, but this histological slide, E&O staining of a normal tendon above with the degenerative tendon below. And a couple of differences I'll show you here is you got these elongated fibroblast nuclei in a normal tendon, but rather in a degenerative tendon, you've got these nuclei that are more round, a little bit enlarged, swollen, and you can see that the difference in color here is a significant amount of increased proteinaceous staining here. So a very proteinaceous product. But what they found, and I know Dr. O'Connor is very familiar with this. He's participated in some of this in the past. Is that looking at tendon biopsy studies, is that there's been a real paucity of anti-inflammatory mediators in most of these tendinoses. And so really it's thought of not so much as an inflammatory disease in the classical sense, but a degenerative problem. But, and this is just another example of showing how disorganized those collagen fibers are. But is that all to the story? And I would postulate that no, that's not all to the story. If you look at some of these areas of tendinopathy, frequently you will see surrounding neovascularity. And these are basically blood vessels that are thought not supposed to be there, okay? And they're frequently seen invading and invaginating and kind of percolating into what was previously a normal tendon substrate. And it's thought that these blood vessels have a pathophysiologic process and play an important role in the development of degenerative tendinosis. And here's up in the upper right hand is an example of an Achilles tendon. This diagram here, you can see the Achilles tendon demonstrated here, and its nearby plantaris tendon, and the surrounding peritoneum. And what we see a lot of times in tendinosis, and these are surgical pictures here, is that people with symptomatic Achilles tendinosis, and this is a lot of this work comes from Dr. Alfredson, the famous Dr. Alfredson and his colleagues. And what they find is you find a lot of increased vascularization at the border, at the interface between this Achilles tendon and surrounding loose connective tissue, whether it's around peritoneum or from a nearby fat structure like the Kager's fat pad by the Achilles, or the interface between the plantaris tendon and the Achilles tendon. And you can see here illustrated all this kind of vascular tissue that what Dr. Alfredson would do surgically, he's an orthopedic surgeon, would be to strip the structures off of the Achilles tendon, thereby disrupting some of these neovessels. And would get better results from this. And he would just leave the tendon alone. And so the theory behind this is that various cytokines and inflammatory and degenerative mediators are malexpressed, causing this increased angiogenesis from the surrounding soft tissue that then basically invaginate and invade the tendon and mediate that degenerative process through the expression of various cytokines, okay? And it turns out that in addition to these vessels, there's also neonerves. So not just vessels, but small nerves that also go with the vessels to invade into these tendons, especially the Achilles. They've done some studies where they've looked at some of the chemical content from that comes from this process, and they found that there's an increased number of compounds such as glutamate, substance P, calcitonin gene-related peptide, histamine, etc. And what you're seeing here are what we call neurogenic inflammatory mediators. So not your classic chemical mediators, not like your prostaglandin mediated or TNF mediated inflammation, but these are typically substances that are expressed by nerves when they're not happy. So this neurogenic kind of inflammation. But it turns out these processes, these chemokines that are expressed, which are typically attributed to nerves, can cause neurogenic inflammation, which then can actually affect the tenocyte population and in vitro actually cause apoptosis in tenocytes. So a lot of Dr. Alfredson's work is looking at, well, what if we disrupted this process? And of course, I've mentioned him before that he would inject polydocanol in the surrounding neovessels, obliterating those vessels, and would show some improvement symptomatically, and actually further out, he would even see some change in the tendon appearance, although not significant, but some change as well. Okay, so here's a study by Alfredson and Oberg looking at injection of polydocanol versus lidocaine to those surrounding neovessels and finding that result of increased or decreased pain. So is it all about the vessels? You know, that's what Dr. Alfredson would focus on. Anywhere between 20 to 50% of chronic tendinopathy is actually Doppler negative for these neovessels. Well, the theory behind this potentially is that you have these invaginating vessels with these neonerves, right? And then you have the surrounding sclerosis and this kind of scar formation and this fibrosis at that same soft tissue interface, which then obliterate the vessels, but they don't obliterate the nerves. And so you continue to have this neurogenic inflammation. And while you don't see the Doppler positivity, you still have this adhesions onto the surface of the tendon with the surrounding soft tissues from which these nerves have sprouted into the tendon and continue to cause neurogenic inflammation. And so there have been plenty of studies looking at both open, mini-open, and tendoscopy, which is a type of endoscopy, approach at obliterating these tissue planes, specifically around the plantaris, separating that tissue plane between the plantaris and the Achilles tendon with fairly good results in people with Achilles tendinosis. And so the question remains, well, can we do this non-operatively? Can we do percutaneous either techniques such as hydrodissection and scraping in order to strip or to provide a Brisement to essentially denervate these neonerves from the tendon? So going back to Dr. Hacken Alfredson again, 2011, and what he did was he compared a mini open surgical scraping of the Achilles tendon in people with degenerative Achilles tendinosis, compared that with the percutaneous procedure, ultrasound guided with a needle, and found satisfactory results at 18 months with a significant decrease in visual analog scale for pain, and there was no statistical difference between the mini open and the percutaneous version of that. Looking at other studies with Dr. Humphrey and other colleagues looking at potentially using a different technique to disrupt that tissue plane, using high volumes of fluid injected into that tissue plane between the Achilles tendon and the Hoffa's fat pad to disrupt those adhesions as well as those neonerves, and found pretty good results with high volume ultrasound guided injections to hydrodissect that tissue plane. Now the goal here is when you do this is that, and this was highlighted in Dr. Humphrey's paper, is that you're looking for the neovessels if you can, and then you do the treatment and then you monitor afterwards to make sure that the neovessels have been obliterated at the end of the procedure. And what he found was improved symptom score as well as decreased tendon diameter. Other studies looked at the same approach to different tendons. And this, I think there's something to be said about tendons near fat pads that was mentioned by Dr. Holsapple earlier. Tom Crisp and his colleagues, as well as Mederick Hall and his colleagues in 2008, 2016, respectively, looked at ultrasound-guided high volume hydrodissection for the same techniques, and scraping. The same techniques applied to the patellar tendon and Hoffa's fat pad, and likewise found favorable results for pain and function both at 9 months and at 12 months, respectively. So this is the case that I'll talk about. So hopefully that brief introduction kind of gives you an idea of the rationale behind it. So on the left here, you have a patellar tendon, both in long axis and in short axis, of a former fellow of mine. This is Dr. Kyle Cucci's patellar tendon. He was not symptomatic, and it looks pretty normal. So here's the hyperechoic line or signature of the distal patellar pole here. Here's the patellar tendon. You can know that you can see that the patellar tendon has that compact fibrillar echogenic appearance here, and it's relatively uniform in thickness all throughout, and is overlying the Hoffa's fat pad here. The short axis view, again, uniform thickness all throughout, a bristled compact fibrillar appearance overlying the fat pad here. Compared here to a patient of mine, and you can see here that here's the patella. Okay, this is distal, this is proximal, and you can see that in that proximal end of that patellar tendon, the distal pole of the patella, there's an area of the tendon that's thickened. There's also kind of a darkened hypoechogenic area. It's a little bit more obscured and less clearly defined, and so you have that effacement of that compact linear appearance of that patellar tendon, and you see similar finding in short axis view as well. But more remarkable, when you turn on power Doppler, you can see this Doppler signal that illustrates this surrounding neovessels. And more important than that is that you can see the pattern actually illustrates this invaginating nature of this almost sprouting nature where the vessels are sprouting from the underlying Hoffa's fat pad into the tendon here. You can see that in both long axis and short axis here. I'm going to show a different case as well, which is even more remarkable. This one right here. So this is actually another patient of mine. You can see it's a lot of neovessels here sprouting in here, okay? And you can see them sprouting in and invading into the tendon here. This is actually interesting. This is a patient who was already previously treated with PRP and came to see me asking to see if he was interested in this procedure and came in requesting the hydrodissection and scraping for it. So some of this is actually hyperemia from the PRP, which was 6 weeks out. But you do see some of these neovessels actually sprouting in rather than being from inside. So there's a little trick that I'm going to show you, which has not been studied, but I think that actually makes sense and can help basically separate some of what vessels are just hyperemia versus what vessels are invaginating in here. There is some thought that the neovessels that are invaginating in typically are a higher velocity. And so I'll see if I can pause. This is the same patient. And what I do is I examine them, and you can see the neovessels here. You can see there's a lot of hyperemia, a Doppler positivity in here versus this. It's kind of sprouting in. I think it's a short axis view. It's looking more distally. And distally, it's relatively quiet in the same patient. Here, kind of in the midpoint, there was actually some Doppler signal. I'm going to pause here for a second. This is the same tendon with slight flexion. So this is about 20, 25 degrees, maybe about 20 degrees of flexion. Put a little bump under the knee. And what you'll notice is that because of a little bit of tension on the tendon, we've kind of obliterated some of that Doppler positivity within the tendon. So my thought is that some of this hyperemia has been made less evident by putting the tendon on a little bit of tension, leaving the invaginating neovessels surrounding this area still visible under Doppler signal, as you can see here. The other thing I'll mention here is that you can see deep to this, the Hoffa's fat pad, there's an area where the Hoffa's fat pad looks noticeably more echogenic. And when we examine dynamically with him flexing and extending his knee, we can actually see some of the fat pad almost snagging underneath the patellar tendon, which is suggestive of adhesions. So this is, again, these are some direct, some indirect findings that suggest that neovascularity, neonerve adhesion forming pathology is present, perhaps in this particular tendon phenotype. And let's see, so same thing. Wish there was a way to fast forward this. But, so again, we're seeing that neovessels here. And again, because the tendon is in slight flexion, or the knee's in slight flexion, we're able to avoid watching those hyperemia. So this is the procedure. This is the tendon in short axis. Here's the needle being introduced deep to the tendon while I push fluid to hydrodissect as well. Now I use a combination of hydrodissection, where I use the pressure from fluid being injected in there to separate that tissue plane, and manipulation of the needle to dissect, using the needle as a tool to dissect that tissue plane. Sometimes I'll use the point of the needle. Sometimes I'll use the bevel of the needle almost as a small cutting tool. And other times I'll use the shaft of the needle to blunt dissect. And what you can see here is you can see the needle snagging on some neovessels there, or adhesions, okay? And through a combination of all those techniques of injection, needle tip, you can see there using the bevel of the needle as a cutting tool and injecting together to split apart that cut that I created. I'm essentially debriding and kind of separating that tissue plane between the hyphus fat pad. And my goal is to get this freely mobile needle underneath, free of those adhesions. Once I'm done hydrodissecting and scraping the posterior surface of the tendon, because he also had 1 or 2 Doppler signals on the anterior aspect, I also hydrodissected and scraped the anterior aspect. He has significantly less adhesions than there's anteriorly, but to be complete, there's one right there. I just wanted to complete that. Now, this next image is the post-procedure Doppler. So as soon as I was done, I put my tools away and turned on Doppler to show that those neovessels have been gone. Now, the tip I'm gonna share with you guys is that once you've assessed all the neovessels and you're about to do your procedure, leave the Doppler where it is. Don't touch that Doppler dial. Do your procedure and then watch it again, and maybe even turn up the Doppler, because you want to make sure you've gotten all those neovessels. I've been in lectures before where people have showed cases, and this image doesn't show it, but you'll look in the corner here under gain, and the gain was turned way down post-procedure. So make sure you don't mess yourself up that way. Don't touch that gain dial. Don't touch that Doppler dial. I mean, you can turn off Doppler, but keep that gain where it is so that when you assess post-procedure, you're really looking at the same Doppler level. Okay, and that's a loop. All right. So take-home points here is that I think that tendinopathy is heterogeneous. I think we're looking at probably multiple phenotypes, and that sometimes it's an intratendinous process, sometimes it's a peritendinous process, sometimes it's mixed. There's several different models for tendinopathy as far as pathoetiology, but I find this to be a useful adjunct. Some people will use this as a standalone treatment, and I have used it as a standalone treatment, but I think that it's also a useful adjunct for regenerative medicine. It's more of an anti-degenerative modality, but I think ultimately enhances the overall result and is a useful tool in your tool bag. So with that, hopefully that was quick enough. I'll take some quick questions before I turn it over to Dr. Andy Gordon.
Hey, Dr. Hill. How's it going?
Good. How you doing?
Good, good. So just to clarify, that trick, it's under like passive stretch, right?
Yeah, passive. Just put a little bump underneath. They're not necessarily loading the tendon per se. What I've done is I have a little roll that I put underneath the tendon to put a little bit of tension on there. And they're not firing the muscle at all. It's totally relaxed. And I think it's something that needs to be studied, but it was something I find to be helpful because I do tend to treat a lot of people who've been treated by others, and they may have had something regenerative in the near, not that far off, and I've got to have to figure out what's what. And so I think that's one of the tricks that might be helpful.
And just second question is, we do not have polydocanol at NRH or MedStar, but I mean, what are your feelings about using polydocanol versus just doing a hydrodissection with a mixture of the stuff we actually have?
That's a great thought. And I think if you talk to Dr. Alfredson, he's a big fan of polydocanol, but he's probably also changed his practice because that was all before he published a lot of his work on scraping and hydrodissection. But based on his earlier studies, I think there's value to it. But I think that it's never been compared head-to-head to scraping. But I also think that, going in and, because I've done it before, we have polydocanol at Fairfax Family Practice. We have it in the cupboard. If you go in and actually try to sclerose every neovessel, it can take a while. It can take a while, and especially if you're trying not to have it spill over and sclerose normal vessels, right? And so I think that when you look at comparatively, comparative to the amount of effort and time, without evidence that one is better than the other, I think I'll favor the scraping over the use of polydocanol to address the neovessels. Secondly, what the polydocanol does not address is the neonerves. And so, again, most of the studies looking at polydocanol was Doppler positive. But like I mentioned before, anywhere between 20 to 50% of these tendons actually are Doppler negative. It does not necessarily mean that disease process is not going, but rather it could be far enough along where the neovessels have been obliterated, and you still have the adhesions, and you still have the neonerves, and perhaps you need to physically lyse the adhesions in the tissue plane rather than just shriveling up the arteries. The reason why we still stock polydocanol is occasionally I'll find AVMs, small, abnormal AVMs entrapping nerves, and you can carefully sclerose those AVMs while releasing the nerves. That's the reason that's the main reason why we still have polydocanol in the cupboard. But I've really moved away from that especially for these tendons near fat pads. I prefer the hydrodissection and scraping Brisement technique.
Thank you.
No worries.
Hey, Gary.
Yeah.
Gary, this is Fran again. And I love this procedure as well. I found it very helpful. But recently talking to Bert Fields and doing, again, a lot of literature review, he has called the question, among others, about the role of neovessels, that are they pathologic or are they actually physiologic and represent healing? And I know there's a lot of controversy in the literature right now about do we want to encourage neovessels, that they're actually nature's way to try to heal, or are they pathologic? Because we use a lot of therapies like nitrous oxide and others that are trying to promote. It's an area of active controversy once again. And I'm just wondering your read, not to, throw you, but just your thought.
No, I think that's great. Actually, I'm glad you brought it up. And I actually kind of maybe very subtly alluded to it by choosing that case to illustrate it, is that there is a difference between helpful and non-helpful vascularization, I think, at least according to the theory, right? And I think that these are all theories, and the best we can do is just study it and get more information. But I mean, based on some of the data that sclerosed vessels and what as far as the outcomes from that, is at least enough to support the idea that there are maladaptive forms of angiogenesis, which we sometimes just call neovascularity. But I think you're right, is that not all vascularization is bad. It's just a question, is it really the vascularization that's bad, or are we using neovessels as a marker for neonerves, and the neonerves are what's bad? I don't really know the answer to that definitively. I think that that's an area of really good study, and that's what I kind of subtly alluded to when I said, how do you distinguish hyperemia versus neovascularity? And I think that I think we're going to have to look at that and figure out different ways. We'd have to have enough of a number in order to get some statistical significance, which I think would be very difficult. Given how heterogeneous these diseases are. But their point is well taken, and I think that these grow back. By the way, these neovessels. I've had people, we do the procedure, you have them follow up, you look, the neovessels are back, but they feel better. And then the question is, did I obliterate the nerves and that's why they're better? And they've regrown the neovessels because they're still trying to heal. So I think it just goes back to treating the patient and not the picture. But that's a point well taken, and that's an area of active controversy. And if any fellows are interested in that, I think there's a real potential there for study.
All right, Gary, I appreciate your time, and thank you for your lectures today. It's been a great opportunity to kind of look at the